Back to the back? Okay. All right, so the topic today is clinical judgment. It's one of your nursing professional concepts. I know that you had this as a concept last semester in level 1, and y'all mainly went over like it had to do with the nursing process and different things like that. So we're going to dig a little bit deeper into it and focus on a few of your exemplars with this. This PowerPoint, I know you have some PowerPoints posted from Ms. Rutherford. I have posted my PowerPoint online for you too, so that you'll have that as well. So critical thinking and clinical judgment are often used in conjunction with one another. Critical thinking sets goals, it's result-based. You've all heard critical thinking, especially since you've been in the nursing program. But the thing is you've been using critical thinking your whole life. You just never called it that. That's just problem solving or whatever you call it. And so it's like an umbrella, and under that umbrella is nursing process and clinical judgment, different things like that. It's purposeful and focused so that you can figure out the best plan for your patient. Clinical judgment, the definition is written there. It's also on your concept map, but it's an interpretation or conclusion about a patient's needs, concerns, or health problems, and/or the decision to take action or not, used to modify standard approaches and improvise new ones as deemed appropriate for the patient's response. So basically, it's looking at that patient situation, and you as the nurse, from your experience and from your background, pulling what needs to happen with this patient. Every patient's different. We can't go textbook for a patient, right? So this is where your play comes in. And watching y'all in simulation, and not just when I say y'all, I mean the whole program in simulation, critical thinking is one thing that we forget about sometimes. We get in there and we see the doctor's orders and we know that we need to put a folding in and we need to give this medication, and it becomes a task. But if you'll remember, a task is something I can delegate to a robot, and he can do a task. But he can't interview the patient to find out if this medication is still appropriate for that patient, if the patient's blood pressure is still okay. And so that's where your clinical judgment comes in. You use clinical judgment before you give medications that require clinical judgment. So like an insulin, are you going to give an insulin to a patient that has a blood sugar of 43? No, you're not, because your clinical judgment tells you that's not a good idea. That patient's not going to respond well to that, so you wouldn't do it. Same thing with the blood pressure medication. You're not going to give a blood pressure medication to a patient whose blood pressure is 70 over 32. That just doesn't seem right. So it's easier to see clinical judgment in those extreme cases, but sometimes it's hard to see it in those near cases. So that's when it's important to talk with you, with another colleague, to find out, hey, I've got this situation, what do you think? You know, that kind of thing. Because not only will you lend expert, but your unit will lend to your clinical judgment. So some of the clinical judgment is based on Tanner's model. Y'all have probably heard of the Tanner's model, or you may have read about it before you came to class. And it goes through the 4 steps of noticing, interpreting, responding, and reflecting. These are similar to the nursing process steps. Noticing is a lot like your assessment. And I'm just going to tell you that that noticing and assessment phase is one of the most critical points in that process, because that is when you are determining what you see, what you feel, that gut feeling you feel. You hear nurses say, oh, I just felt funny about this patient, and the next thing you know, the patient codes or has to go to ICU, or an RRT is called, or something like that. I just didn't feel right. That's part of your clinical judgment, coming out and saying, stop, look at the patient, really look at the situation, and find out what's going on. Interpreting is your intervention. What am I going to do with this patient? Now that I know that there's something wrong, I check the blood sugar, it's 43, I'm not going to give the insulin. That's my intervention, right? I'm going to look at the orders, maybe I'm going to give D50, or I'm going to give some juice or something. And then responding is actually doing the action. The reflecting part a lot, you can reflect in and on action, and we'll talk about that in a little bit, but the reflecting is going, okay, what could I have done differently in this situation? Maybe I didn't notice that the patient's blood sugar was 43. Maybe I missed a step. What could I have done differently? Were my interventions positive for the patient, or were they negative for the patient? And that's how you're going to build your clinical judgment base as a nurse, because you're going to look back and think, I remember I had a patient that was 43 and I gave her the insulin anyway, because I didn't check the blood sugar. so from now on, when you have a diabetic patient, I guarantee you the first thing you'll check is their blood sugar. So it builds off of your expertise too. So noticing, if the nurse notices a change in the clinical situation that demands attention. Interpreting, the nurse interprets the situation and responds with an appropriate intervention. Responding, the nurse responds and acts accordingly to the situation based on his or own clinical reasoning. And then reflection, what occurred as a result for action. And reflection in action is like I'm going to give Ms. Rutherford some pain medicine because she's hurting. But while I'm there, I'm going to see if whatever I'm doing is making a difference in that moment. Does that make sense? Staying with that patient, watching that patient. You have a patient that's got, it's very tacky and they're going to give them a dentist, and I'm going to wait in that moment and see if my intervention of giving a dentist can help that patient to become back to normal times for them. Does that make sense? So that's in action. And then on action is like after the situation's over, you've had a code, you didn't see the code coming, you missed it. You're looking back and you're thinking, what did I miss? What could I have done differently that would have changed the outcome for this patient? So that's your reflection on action. So I went through each exemplar and pulled out like a little, how you would practically apply this to a situation. So for clinical, the nurse notices a patient complaining of pain at the IV site. The nurse interprets that the pain is that the IV is contributing to the IV being infiltrated. And the nurse removes the infiltrated IV. So a reflection question would be, how did the patient respond to my action or intervention? So it's an urgent emergent, kind of like what we talked about. The nurse notices that a patient has SpO2 level of 70% or more now. The nurse interprets that this is not good for the patient and that the patient may be in respiratory distress. And so she calls an RRT. Now, did she miss something along the line? Maybe she didn't assess the O2 stat when she first walked in the room for her assessment. Maybe it was already trending down and now it's 70 and the patient is. And so what could she have done differently? Medical management, the nurse notices that 2 of the 6 patients assigned have 7:30 medications due. She also notices that's the time that meal trays are going to be passed. So she responds by administering the medications to the 7:30 patients and then waiting until after the meal trays are done for most of them that have medication. So it's prioritizing also. You have to remember that in nursing, prioritizing never goes away, whether it's a big ABC thing or it's a little, I'm going to prioritize my time management, my patients, and things like that. Another example, and this is one that I think applies in almost every instance of healthcare, whether you're nursing in the hospital or not, is when to become the healthcare provider. And that's something that we try in the sim lab to simulate, because I know you don't get a lot of practice calling clinicians in the hospital, usually the nurse will do that, but that's an important thing to get used to doing, and we'll watch something later that will show you some examples, but this one was interesting. The nurse notices that a patient has a medication to an allergy to a medication, that the physician just wrote an order for it. The nurse interprets that the medication allergy is non-emergent because the patient's not going to get this medication until they're discharged. Okay, so they're not being discharged today. The nurse informs the charge nurse of the medication allergy and leaves a note for the physician saying the patient has an allergy to this medication, needs to be changed. So you can see how that went a different way than what you would have thought. You immediately think, oh, I need to call the physician right now because she has an allergy to this medication, and he just wrote for it. But is it emergent? Because she's going home, could you cluster your calls? I guarantee you'll call him at some other point in the day, and you can leave him a note as well as he. You see what I'm saying? Like that, noticing the difference between emergent and non-emergent, and could I cluster it? Because I'm going to have to call him later with his CBC or something like that. It'll save you a lot of yelling from the physician. Another part of clinical judgment is medication administration, and with that comes the medication right, which I know y'all know all the 6 tracks of medication administration, but you can't stress it enough because your license is giving that medication, so making sure that you have the right dose. And being in clinical with students and seeing just the tiny mistake of, oh, I didn't cut that pill in half, but my instructor caught it because it was a half dose, you know. Just really verifying, you can't check it too many times, you can't check your order too many times, and making sure that it's all correct, is a big part of nursing. So I have a little activity. Ms. Rutherford's going to pass out these poster boards for y'all. On the back of the poster board, written in a little pen, is a drug. Whoever, if y'all just want to group yourselves just in a group, I think there's 6 groups. So group yourselves, and then on this poster board, it's up here on the screen, but you're a new nurse on the floor and you're using your clinical judgment. This patient has got this medication that you've got written on the back of your board. What does the nurse need to know before administering that medication, and what information should you give your patient? What education should you give your patient? And then we'll hang them up, and if you don't want to take pictures afterwards, you can. But we'll pass out markers for you.
Yeah, this just happened. It's so loud. So what is it?
So you're talking about his women.
What we need to know and what we tell them. What we need to know before administering and then what we tell them.
So everything's like a drug card and then
Patient identification. I used to go to this girl at Massage. It's her
that's good to know because
or so just a trip. And so then I went to Providence 2 times last year. And I wasn't satisfied. Nobody else is like on this side, it's like cut up. I'm going to take Isaiah back. Plus I get this thing in the room.
it's a high
I know. I haven't dyed my hair.
little bit small. You know how to spell, that's why you're asking us. Alright, that makes sense. I know how to read, but that's I'm gonna take a picture and send it to you.
I was 15. I used to cut myself when I ran away. As a grown-up, I wanted to do that. So I can have a nice, quiet place to be. I don't have to cook. Last night, he's trying to get on to the point. I've never had a problem before. You know, there's always like you're at it. And then he had to take a quiz and he got on it. I was like, I think that's it. He's checked up on us. I just like seeing the deal. I would even me too. That's my belt. Like, I'm not ready to do it on a regular person. Someone that's not like that. You know, yeah, I know. Sarah, quit talking fast. That's fine. I don't say anything about that. She did a little bit yesterday. You should watch the video. I need to. She what that lady does. She's got good blood flow to the areas. I think she might be on the and so she finds a way that she says, so you're stopping the blood flow. So then you'll see, I know the blood flow. And then when you push the blood out, and then it's going to backflow, you know, back in this way. And then you'll see an area where, like, here's where the blood is, and then here is where there's still no blood that came back. So that means right here is that value. So you want to go up here before you get to this. I think it's that's my thing.
Yeah, the other thing we have to worry about is I'm a DC.
Yeah.
So, one of the biggest things is run out
there's like a week and a half, and it's like, I should take it. So I did. I don't know. They're like, they're not like hard, but yeah, but they have like it's like, I left them there for a week and a half, so I can't forgot it's under
So we take away
You've got about 5 minutes left.
Yeah, that's right. She's like the kids.
Take it up.
And they I spent like a $50 in one tier.
Someone else is talking, I go Tara.
When it starts around here, that's gonna stay oh, yeah, that's like she's like some Spanish descent or something. She has a strong accent. They were talking about food and stuff, and she's like, they were talking about something
I just had random knowledge, but stuff down She's really loud. Remember the album?
Anti-diabetic helps to lower the blood sugar. Side effects, this is here, the hypoglycemia, headache and dizziness, and things that we should watch for. Check the blood sugar before we administer it. Too low, don't give it, obviously. And then for the headache, just to check pain scale after the dose, and then for dizziness, to check the fall risk after the dose. Patient teaching, just to take the medication regularly, like on a scheduled time. Teaching them how to monitor their glucose levels and to check them using an AccuCheck or whatever machine that they use. And then lifestyle changes, they need to watch what they eat, lose weight, go on a diet and all that stuff. And then advise your client of side effects, and if anything major happens, to just notify their physician.
Okay, listen, did y'all mention anything about the dye? This medication with IV dye contrast. So an important thing with the metformin or the glucophage to remember is if the patient's going for a CT scan with contrast or an MRI with contrast, they cannot take the metformin before they go down and for days afterwards. So that's something to really watch for with metformin. Also, if you'll look in literature now, hypoglycemia is a rare side effect with this diabetic drug. This drug in combination with other diabetic drugs can cause hypoglycemia. But the reason a lot of physicians will prescribe metformin or glucophage is because of its decreased risk of hypoglycemia. Just an interesting little tidbit on that. I just learned that not too long ago. So, but anyway, the IV dye is a big thing that you'll want to watch for if they're going to go into surgery or the heart cath or something like that. They'll ask if they've had any metformin in the last 24 to 48 hours. But good job. And y'all can hang your poster here and then afterwards.
Great job,
Okay, next is Rosamund.
Alright, Cody. Pick it up, Cody. Pick it up, Cody.
Good job right there. We're wearing this. I think we're like.
All right, I'll do this.
Thank you. Go back here.
Oh, man,
We gotta get in front of the camera, bro.
well, I need somebody here.
Actually, you just need that vest. That's all you need.
Let's go. So, you want to talk to me?
All right, we got Rosamund, aka Lasix. You know, usual dosage is 20 to 80 milligrams. It's a loop diuretic, and you know, yeah, it's going to treat some fluid retention. And what we're going to educate the patient to do, we're going to instruct the patient to take drug in the morning. Inform the patient of possible needs for potassium, magnesium, or calcium supplements. You know, we're going to want to monitor the fluid and electrolyte values as well. And, you know, monitor blood pressure, the glucose levels, the weight, and the eyes and nose. You know, side effects. You can tell about the side effects.
All right, so where's the side effects at? Oh, okay.
Right underneath your thumb.
So we got frequent urination. So you go, you know, pretty frequently. We got headache. We got some dizziness. Some constipation might happen. That's no good. We got hypertension and nocturia. What? Nocturia. So I guess they go through frequent urination. Yeah. And that's the side effects. Y'all got it?
Okay, so here's my questions for it. Is this a potassium sparing or potassium wasting?
Potassium
Wasting. So a lot of times you'll see patients that have borderline low potassiums on a potassium supplement with this medication. They'll also come in if they're at home on this medication, because right it can be PO as well as IV. They'll come in for routine blood checks to make sure their electrolytes are not off. As a nurse, are you going to push it slow or fast? Slow. And you're going to dilute it. That's why they'll dilute as well. So it is slow. If you push it too fast, they can get the ringing in the ears and different things like that. So, good job.
Appreciate it.
Y'all can hang it up here. Make that well.
His name was Jonathan Taylor, and Jonathan Taylor was a perfect specimen, but at 65 years old, Jonathan Taylor collapses. His heart begins to go to nuts, and as the paramedics get there, they take him to the hospital and they rush him, and one of the drugs that they will give him is Metoprolol. So why does Jonathan get this drug? Well, the reason he gets it is because it's antihypertensive. And Jonathan has had a long history and battle with it. And so then what it actually does is actually a beta blocker, and it decreases cardiac output. And side effects include the hypertension, bradycardia, fatigue, and diarrhea. Anyway, so when you're doing this, some of the implications you want to do is you want to check the apical heartbeat, the pulse. Before administering, it has to be at least 60 beats per minute. If it's anything lower, you have to let the physician know, or let somebody else, make sure that it's at 58 or 56 minutes. One of those things you have to check, okay? Informed patient drug must be withdrawn gradually over 1 to 2 weeks.
So if you're going to stop stop taking the drug, it has to be gradually stopped. You can't just stop taking it.
And also take the drug exactly as prescribed with meals. So just like anything else, you want to make sure you have something in your stomach. So you don't take it and you don't get bad stuff. Also, does anybody know like another drug that you might not get with this? Something that we studied, like the skills. Anybody? Taylor, would you like to know? Anybody? Something like the Johnson, you know, or anything like that. If you're ever combining drugs, you want to make sure that it doesn't work because it's already causing bradycardia. So anyway, Jonathan's, everything's fine with Jonathan. He goes home, he's a picture perfect.
Okay, what does thyroxine?
Takes care
Okay, we have levothyroxine, which has another name of Synthroid, and just like the trade name says, it helps with thyroid. It's a thyroid hormone that can help if you have a thyroid acne. The action is basically to increase the basal metabolic rate, and it enhances glucosagenesis, which helps when you have thyroid and keep your eyes poking out of your freaking head and make you look like a fly. It's not pretty, okay? It's not. No. Some of the side effects of the medicine, if you have hyperthyroidism, it will be irritability, insomnia, hyperthermia. Not fun. Some general ones are going to be weight loss, complications, tachycardia, increased blood pressure, arrhythmias, and cardiac arrest can be a very bad one. It can also cause diarrhea, as the picture in that book shows. Scars for life. Normal doses for anyone under 50 will be 1.7 micrograms, 25 micrograms. It actually comes in a really tiny tablet. It can be crushed, or it can also be diluted into an IV station. And then for anyone over 50, it's 25 to 50 micrograms. And for the patient teaching, you have to take the med on an empty stomach, just with some water. You can't really drink anything else with this medication because it's counteracting it. It's just like that. It's a lifelong med, and there is really no stopping it. You have a thyroid, you need something to stop your blood, but like that. Avoid changing brands. Don't be cheap, stick to what they give you. Okay. You have to test tablets from light and moisture. Anything from the week. And then for some of the nursing implications, you're going to be monitored for increased pulse rate and rhythm, just because arrhythmias, cardiac arrest, and myocardial infarction. Bad. Report abnormal vital signs of pulse under 100 BPM or abnormal BPM. Basically, monitor their heart. The biggest thing that you have to do is monitor the patient's heart rate, their pulse rate, their blood pressure, anything having to do with their heart. Monitor it because it can get bad.
One question. Which disorder did you say exophthalmos was with? Which of the disorders did you say that exophthalmos was a side effect of? Or a complication of? The big eyes?
Oh, the big eyes, hyper.
Hyper, good.
Yeah.
Okay, and so one other thing you want to point out, that they're of childbearing age, you want to make sure that they know that their dose will need to be adjusted once they get pregnant, okay? And then also, I heard you mention for no thyroid, like if they don't have any function in their thyroid, also low thyroid also need the medication. So, good job, that'd be great. Okay, warfarin?
Is everybody ready? So we have warfarin. It's an anticoagulant. So basically what you want to do, you always want to draw blood to establish a baseline for coagulation. You want to give the drug at the same time. Don't take it at morning one time, take it at night the next. This actually can cause major bleeding if something go wrong. You want to avoid iron injections. It does come in PO. That's preferable to give to your patients. Patient education. Okay, so your patient needs to avoid acetaminophen and any aspirins that can increase bleeding. When they shave, if they're a male, I think women shave too, but you want them to use an electric razor, because if they use a regular razor, they can cut themselves and bleed everywhere. You want to avoid foods with high concentration of vitamin K, which is potassium in this case. They can't drink alcohol. Preferably, you don't want them to drink alcohol, so you always want to stress that to them. Side effects that can warfarin can cause are nausea, abdominal necrosis, bleeding, and fever. There's 6 considerations that you want to have. It can be contraindicated with bleeding. You can have severe hypertension. You want to assess signs of bleeding, and if your patient is bleeding, you always want them to report that. And that's it.
Good job. One thing you can also remember, because this drug interacts with almost everything you can think of, okay, so make sure you always check your interactions with a patient on this. So why would you want to watch for potassium? Why would you want to tell them to watch their potassium foods?
I believe that potassium can increase in the thinning of the blood.
Well, potassium, if you'll notice a patient that has a really high INR level, well, the antidote will be vitamin K. So you have to watch the potassium foods because they can have a lot of that in there. So that's like their green leafy vegetables, different things like that. And then, no, I think that was what I was going to say about that. Okay, well, that's good. Good job, y'all. That's our market. Sorry, questions?
Yeah, that's who I go to or used to do it. Seriously, I wanted to grow all one way.
All right, heparin.
All right, we got heparin. It's a blood thinner. I think it's more of an inpatient drug than an outpatient drug. It comes in 2 forms, IV or sub-Q. Indications for using it. People that are high risk for embolism. If somebody's stuck in a bed, they use it with the CCDs, other ways to prevent that clot. After surgery, they have high lipids, so they're higher risk for throwing a clot, or history of stroke, not in the last 4 weeks, or history of cardiac or peripheral vascular disease. Contraindications, blood in the urine or stool or the gums, that means they're too thin, so that's something to watch out for. Active internal bleeding, so if they're already bleeding, you don't want to make them bleed more. Breastfeeding, or if they're pregnant, they're not supposed to have. Patient education, teach them about side effects, and the main side effects or the signs and symptoms of too much bleeding. The nice thing is it's really inpatient, so that's going to be on us to watch before they do. Avoid high-risk activity, so things that put them at risk for falls you want to try to avoid. Before administering, check platelet count, blood pressure, check for excess bleeding, probably also skin breakdown. That's better.
So a lot of times they'll have this in the hospital and they'll go home on Lovenox because it's a weight-based blood thinner. So you do have to watch all those things. Remember, this can also be a drip on patients. They can have a heparin drip, and pharmacy doses that according to their levels and things like that. It's contraindicated in pregnancy unless you have a clotting disorder. Maybe you had miscarriages because you can't keep the baby, and so sometimes heparin is what they'll put you on for that. So, anyway.
I like to, as far as when I was a student, I would try to memorize stuff. And there's, that's easy. Sometimes you have to have ideas put in your head like me. And so what lab did you say? Check. Did y'all say any lab work?
Wait, the counter, I guess it's CDC.
So, but then you need to check the, like if somebody getting heparin, they check a thrombin time, a PTT. Just like with Coumadin, they check a PT, INR. Okay? And so you spell out the word Coumadin. C-O-U-M-A-D-I-N. 8 letters, right? So if you're on a test, you go, is it a PTT or PT? Well, there's 2 fingers left, so it's PT, right? So you spell like heparin, H-E-P-A-R-I-N. There's 3 fingers left. T-T-T. Okay? So if you're on a test, you can't remember.
Your hands and feet.
Yeah, so, and I would say, like I was telling my students yesterday, if you're given a drug, know what the reverse lazy is. I heard somebody talk about vitamin K with Coumadin, right? Or warfarin. So, did y'all, maybe we're fixing to go with it.
No, go ahead.
So with heparin, what do you get for heparin overdose? Huh? It's protamine sulfate. Protamine sulfate, okay? Yes, ma'am, in the corner. And then, what else was it? There's something good else to probably be on this test. I'm just kidding. There was something else. Anyways, I think I'll tell you. But I just wanted to give you all those little things for the fingers, right? So heparin, PTT, Coumadin, PTT, right?
That's good. I didn't know that. So just important in my word of advice to you is when you're giving a medication, make sure you know if there is an antidote in case the patient gets too much, a reversal agent that's going to take the drug out of their system. That's important. A lot of the pain medications you can reverse with Narcan, different things like that. So it's just good to have that in your brain, like in the back of your mind. Okay, if there's too much of this circulating in the patient's system, what am I going to do? If there's nothing you can do, there's nothing you can do. But if there is, then you want to do that. You want to know that and have that in the back of your mind at least. So. Okay, so the next thing I want to talk about is SBAR. And some of you have probably practiced that in the sim lab. If you have not practiced that in the sim lab, you will, I'm sure, have an opportunity to call me, and I'll be glad to hear your SBAR. SBAR is one of the most, I think, important ways for you to get your point across as a nurse. Everybody's nervous when they call the physician, and they don't want to get yelled at. So having all the information that you can have readily available will help you calm down and help the physician get the correct information that he needs. So what are some important things that y'all can think of that you might want to bring to the phone call before you call the physician? What would you as the nurse need to have ready?
We want your vitals and your the last medications you give. Definitely what's the situation and
So that's right. You want to bring your vitals. You want to know a background on your patient, a history on your patient, any allergies the patient may have in case the physician doesn't know. You have to remember, some of these physicians that are seeing our patients in the hospital are not their primary care physicians, so they don't always know what's going on with them, and they may not remember them from the 300 patients they saw last week. So you're their way of reminding them of who this patient is, what they're here for, patient with any history, different things like that. So it's important to make sure that you bring all of that you know all of that. And then obviously why you're calling. They're going to want you to get to the point. They don't want a whole long story, but they want a little bit of background, let them remember who this patient is, and then tell them what you need. So as far as what you've probably heard, in new research, they're looking at ISFAR, and that's basically identifying the patient first before you bring the situation into it. So that's just who the name, the age, the weight, things like that that the physician may need to know. And I'm going to show y'all some videos on SBAR. The first one is not the way you would want to do an SBAR, and then the second one is the way you want. They're real quick. So watch these for a second, and then I'm going to give y'all an opportunity. This is something that you will do in your nursing career many, many times. So I want y'all to get familiar with it.
Oh, hi, Dr. McCarthy. Do you have a second?
A second?
Sorry, I just wanted to talk about Mrs. Holmes.
What's up?
Well, I spoke with nursing after rounds today. I was wondering if we should change her pain medication.
I'm sorry, who are you?
Oh, well, I'm John, the pharmacist on the stroke unit, while Tanya's away.
Why change your medication, John? Why wouldn't we just up the dose?
Well, the current med isn't fully relieving her pain, and the team says it's making her drowsy, too tired for her therapies. She's reporting her pain at 7 out of 10 for the last,
Okay, what are you suggesting?
Well, I don't really know this patient very well. I could review her chart, but that might take a while. I'm not going to be here tomorrow. Tanya's coming back, so maybe this should wait. But Mrs. Holmes is really hoping to be home for the weekend, some big anniversary, and her husband is coming in this Thursday, so maybe one of us should talk with him.
Okay.
Hi, Dr. McCarthy, is this a good time? I need 3 minutes to discuss Mrs. Holmes. I'm John, Dr. McCarthy, is this a good time to the unit?
I have a few minutes.
I need 3 minutes to discuss Mrs. Holmes. Concern from I'm John, providing pharmacy situation is that Mrs. Holmes' pain isn't being well controlled. She's sedated, which is having an...
One more time.
Hi, Dr. McCarthy, is this a good time? I need 3 minutes to discuss Mrs. Holmes. I'm John, I'm providing pharmacy coverage to the unit.
I have a few minutes. What's up?
Nursing raised a concern from rounds this morning. The situation is that Mrs. Holmes' pain isn't being well controlled. She's sedated, which is having an impact on her participation in therapies, and she's continually reporting her pain at 7 out of 10. Now, the background is that she's fallen 3 times since her admission to rehab, and she's requesting to go home at her first pass this weekend, some big family anniversary. But my assessment is that we are not adequately controlling her pain, and what we're giving her is contributing to these falls.
Okay, so what do you recommend?
Well, after reviewing her chart, I'm considering lowering her dose of opiates and introducing an anti-inflammatory, which would be less sedating, and she should be able to tolerate.
Yeah, that makes sense.
Her husband is coming in this Thursday at 10. If you're available, we could meet to discuss.
Okay, sounds like a good plan. Let's meet back here and we'll talk to the family together.
Okay, so you can see how just organizing the information really makes a difference for you and the physician. It kind of keeps your thoughts clear as well as lets them know what's going on. So really when you have this opportunity, because you may not have the opportunity a lot in the hospital to call the physician or talk to the physician face to face, use this opportunity in your sim lab experiences to practice your SBAR, because it will be something that you'll use throughout your career as a nurse, and they'll want to, the more that you can have available and ready. I can remember when I was a first brand new nurse, I'd come and I'd have my whole paper laid out with all this information, and half the time they didn't need to know everything that I had written on there, like their labs or their mother's birthday or whatever I had written on there, but I had everything just in case. So it's just important to know a lot about it. The same thing goes for your patient falls out and goes into a code. You're the reporter for that patient, okay? So you're the only person in the room that knows the information about that patient. Your charge nurse may be in there and they can help too. But when that code team arrives, you're the one that's going to be giving that information to them. What's the background? What's the situation? What happened right before this code took place? What's the patient's history? What happened? And so you're there. You're the person that's relaying on it. So it's good when you start a shift to know about as much information, to read the physician's notes, read the history, physical, know as much as you can, because if something does happen, you're the person they're going to ask. Okay, so next you're going to just like say where you are, but you're going to turn to your partner and you're going to kind of practice an SBAR. So this is your patient that you're taking care of on the floor. And then, so it's a 68-year-old lady that you're taking care of on the evening shift. She's 2 days post-op of hip fracture surgery. No problems were noted on the nurse when she gave you a report, other than she's been complaining of pain, which she's been receiving her pain medication. When you perform your head-to assessment, beginning of her shift, you find that she's starting to be confused. So now you're going to, what information would you need to gather prior to contacting the physician? And then now you can turn to someone and you can give them the report based on what your findings are. This is what you have, so how are you going to give the physician a report? It'll just be like 5 minutes. Okay, so I'm going to throw a little bit more information into your case study. So the physician then asks you to get a chest x-ray, ABG, EKG, and chemistry studies of CBC and CMP. So what other information would you need? Or what are you going to do with this information? Is there any additional information that you would need to know?
What did you say after CBC?
Chest x-ray, ABG, EKG, CBC, and a CMP. She said you wouldn't want another previous levels. You would want to like be able to compare or be able to tell him when the last time she had one drawn was, maybe before that morning for the routine lab. One thing you may want to ask is, do you want me to call you with these results? A lot of times now with the digital charts and everything, the physicians can log in themselves and see the results. But you want to make sure that you're putting that in his ballpark. What does he want you to do with those results? Also, are there any parameters that you're looking for, like call you if it's, I used to work on an oncology floor, and so we did a lot of blood transfusions, and they would say, call me if the hemoglobin's less than 10, or something like that, or transfuse if the hemoglobin's less than 10. So are there any parameters you want to give me based on this new blood work plan that's coming? Okay, so the chest x-ray suggests pneumonia, and the resident orders an IV antibiotic. 2 hours later, you start the antibiotic, and you note the patient is more shorter breath. You request the resident to reevaluate the patient. The patient's O2 stat is now 88% on a 50% face mask, and her respiratory rate is 30. You feel she's almost a 1-to-1 nursing ratio of need, and you're worried about how you will care for the other 3 patients that you have. You ask the resident if the patient should be moved to the ICU, but he states he wants to see how she responds to the antibiotic first. What should you do next?
Delegate a nurse's aide to stand one-on-one with the patient.
Okay, but remember, a nurse's aide is not a licensed person, so they can't make any judgment calls on it. So if the patient starts to deteriorate, maybe they would recognize that, maybe they wouldn't recognize that. So, well, and you have to remember that unlicensed personnel can only do so. There's only so much scope in their practice, and you don't want to do that always. So, what else could you? If you're really concerned, the physician leaves. He says, "I'm going to come back. You just let me know how she responds to the antibiotic." What else could you do?
Maybe talk to the charge nurse and like express your concerns to her.
Especially as a new nurse, your charge nurse is a wonderful person to talk to because she's got the expertise. So when you're out there and you don't know what to do, you can talk to her. You can talk to other nurses that you know have been nurses and understand, what would you do in this situation?
You could talk to the respiratory therapists and consult with them, and then you could probably get them on a continuous pulse ox machine that has an alarm hooked up to it.
So continuous pulse ox has to be in order.
Does
The
it?
physician will have to order that for you to be continued. You can spot check them as many times as you wanted to, but for a continuous pulse ox, usually that's in order. Me, if this were my patient that I was taking care of, the physician has now left. This patient is my responsibility, right? So if this is what the patient is doing, and it's progressively getting worse, she's not getting any better. We've started the antibiotic, and she's becoming more short of breath. The picture's not getting better. I would call a rapid response team. That gives me another group to come in and look at that patient as well. It's not the physician that just left. He may still be in the hospital. Maybe he'll come to the RRT. That's fine. But usually it's an ICU nurse and a respiratory therapist that'll come up, as well as the house supervisor, and they'll take another look at that patient. Although the physician thought, no, we don't need to move this patient, it's fine, he may not understand the one-on-one care that you can actually give a patient like that, right? He doesn't realize the other 3 patients that you have. And so it's important to remember that those tools are in your toolbox, and those rapid response teams are there to prevent something worse from occurring. So it doesn't mean that patient's going to get moved. It doesn't mean that anything like can happen with the patient, but it gives you another set of eyes to come in and look at that patient and to see, am I missing anything? Y'all feel the same my gut feeling just doesn't sit right. Many times I've called an RRT just because my gut feeling doesn't say that this situation's right. And then the patient may get moved to ICU. You know, they see a need for it, so.
But you also said you talk to your charge nurse, but so wouldn't you talk to your charge nurse before you call the RRT?
You probably would, but usually when you're calling an RRT, everybody kind of around the floor knows when you're calling an RRT. You're gonna let your charge nurse know that you're calling an RRT as well. I mean, because she's gonna be in there helping you. Somebody's gonna take over your other 3 patients while you're in the RRT. You see what I mean? So it's gonna be, she's gonna know, but you will, it's kind of simultaneously when you do that. You tell her, hey, we're really worried about Miss Jones and 204, and she's not looking very good. I think the physician said we're gonna wait, but I just really don't feel good. She's gonna recommend you probably call an RRT.
This is also, unless it's a drastic change, the information that's passed on in huddle in the morning, we always ask if anybody have any critical patients that we need to watch closely. So if it's something that's been gradually happening or going on, everybody's going to be aware.
Do some of the physicians count that and like kind of take that as stepping on their toes or going past them when you do that? Like, will they get mad at you?
You're your patient's advocate, so you can't really worry about that.
Well, no, I know, but I'm just saying, like, it doesn't happen. Will you get chewed out by a physician or doing something?
He may or may not ever know that you can call an RRT. And if he does, then you just, I mean, you have to say, this is my license, it's all I don't feel comfortable caring for this patient. This is what I felt like was needed, and then, like I said, it may result in nothing. That patient may stay on your floor and you may care for the patient the rest of the day. Or that patient may get moved. You know, the house supervisor say, oh yeah, this is too high of an acuity for this floor. Let's move him to the ICU, we've got open beds, you know, that kind of thing. Staffing is better down there, so. And if your ratio really is 1 to 4, you're doing really good. So, I mean, you think about that. You think, you know, there were nights that I remember having to date. And so if you have one that occupies a majority of your time, you're in trouble, you know. So you have to look at all that. And the physicians, like I said, don't know the staffing on the floors. So their only concern is that patient, and that should be your responsibility. My concern was this patient and the care that it was getting. So the main thing is that when you're talking to physicians, it's okay to be assertive, right? We kind of tend to say, okay, whatever you say, I'll do, you know. Just remember that you're the one that's actually administering that medication or going through with the order. So if you don't feel like it's right, it's okay to get clarification on the question. You don't have to be rude about it, but you can just nicely say, could you clarify a little bit further what you're meaning or why we're doing this or things like that. Because they can make mistakes too. And if you're asking a clarification, may show them, oh wait, I didn't mean that, I didn't want that. That's also why it's very important when you're giving an SBAR report to a physician to read back what you said. If I called Dr. Rutherford at 2 in the morning and I'm asking her what she wants to do with this patient, I'm very alert and very awake and I know what I'm asking, but she may have just woken up her out of a deep sleep, and she may say something that she doesn't mean. And so when I repeat it back, it may jar her head and say, oh, that's not what I wanted. No, I mean this, or I mean that dose is wrong, or something. So it's very important to read back what you may have heard wrong. Maybe you have a bad cell phone connection, you may have heard wrong with him. So it's important to make sure that you read back the information. Okay, last part that I want to do is I want to show you this video. This is kind of like what we just went through with this lady, but they acted out for you. And so it's going to show you a patient that's deteriorating and how the nurse handles it with a physician. And then I'll ask you some questions. Well, can we get the lights?
Hello, my name is Stephanie. I'm going to be your nurse this evening. How are you feeling?
So tired. I can barely keep my eyes open.
Do you have a history of urinary tract or kidney problems such as surgery, infections, kidney stones, cancer, sensitive bladder? Have you had a pregnancy? Sexually transmitted disease? Have you been taking any antibiotics, muscle relaxants, medicines for neurologic or stomach problems? Have you been experiencing any urinary retention, urgency, frequency at night, burning during urination, nausea, vomiting, or chills?
I take Tylenol and yes, birth control pills.
She's been really run down the past few days. I'm really worried about her. She's been in her bed with the covers over her head, not going to class, complaining that her back has been hurting. Actually, she's had a heating pad on it.
Yeah, the life of a college student. She's probably just tired from studying and staying up late. She just needs some IV antibiotics and IV fluids. She'll be much better tomorrow.
She still has a temperature of about 102 and her heart rate is up to 120. I've given her Tylenol twice during my shift, which seems to help her just fine. She also has IV fluids running at 100 mils an hour.
Why is she still so febrile? Something else is going on. Could she be septic? She has a new documented infection. Her temperature is greater than 100.4, and her heart rate is greater than 90 despite IV hydration. She may have to go to the ICU if she continues to decompensate. Sarah, this is Stephanie. Can you wake up for me?
I think I feel a little bit better today.
According to our hospital guidelines, she meets several criteria for activation of the rapid response team. 1, I'm worried about her BP dropping. 2, her heart rate is 116 and respiratory rate of 28. I'm going to call. I'm not sure it's entirely necessary. I hope I'm making the right decision. Yes, operator, could you please page the rapid response team? And then you go to room 221. Right. Patient's blood pressure is dropping. Thank you.
Okay, we're here. Why did you call us? What seems to be the situation?
This is Sarah, and she goes to the Edward Winter University and came into the ER with pyelonephritis. She was admitted yesterday afternoon. She has no remarkable medical history. She has a temperature of 102.8, and I'm worried that she might be septic.
Well, what would you expect? She has a UTI. She probably just needs a little more fluid. So did you really need to call us? You know college kids. She was probably out late each night.
What's going on here? Is she okay? If she hasn't been feeling well for a while and she hasn't been out at all.
Anyway, we'll take it from here. She's still febrile and tacky. When did she get her last bolus of fluids?
I received your page and I heard the rapid response call overhead. What's going on with my patient? Can you handle this for me? It is just a complicated UTI. I've got another patient consult in ED. I'll be right back.
I'm here, nurse. Okay, for reporting no chance.
Let's give her a fluid bolus of 1 liter. When was her last acetaminophen? Why are you hanging lactated ringers? She needs normal saline. Please pay attention when I ask for a medication. And why did you give her acetaminophen? She had it 2 hours ago. Please change the fluids to normal saline at 1,000 milliliters over 20 minutes. Recheck her blood pressure after the fluids and draw lactate and blood cultures.
I just took her temperature is 102, heart rate of 100, respiratory rate of 24, and a BP of 86 over 40.
Wait, Marie, can I talk to you for a second? So are you going to move her to the ICU and initiate the severe sepsis protocol? I think I should notify Dr. McCormick first. I want to know what she thinks about this.
She needs to be moved. You can check with Dr. McCormick, but the rapid response team is responsible for her treatment. We need to move her to an area where she will be monitored.
Yeah, she needs to be moved, but the rapid response team doesn't realize how sick she is. I'm concerned about her BP dropping too quickly. She's not responding to treatment, and she won't be monitored closely enough in the step down. I wish they'd move her to the ICU. I still think I should notify Dr. McCormick, but I'm not going to disagree with Marie. There's not enough time for that.
So let's repeat the plan. I will facilitate her getting a bed and step down. Dr. McCormick, please put in the transfer orders and be sure to include the sepsis protocol.
Please call me if her pressure drops below 85.
And will you come back to see her?
Dr. McCormick and I will be back to see her after she's admitted to step down. If you have any concerns about her or if she gets worse before then, please call us.
Okay, so you can see how the nurse had that gut feeling this whole time. She wanted things done. Things didn't always get done the way she wanted them done, but she kept on and on and on. So who are the members in this team? So we saw the nurse, and we saw Marie, who came up with the RRT team, and I think she was a nurse practitioner. Normally that's going to be in your hospital setting. It's usually going to be a respiratory therapist and an ICU ER nurse that are assigned to the RRT pager. And then, what elements in this scenario contributed to the patient's outcome? So what do you think could have been done differently, or needed to be done differently? So they didn't feel like a cohesive team, did they? They didn't all respect each other's recommendations or opinions, and then she still felt like she needed to go above Marie's head, maybe to the physician, but didn't want to step on Marie's toes. So you just have to remember in that situation, what is my ultimate goal? Am I worried about offending Marie today? No. Will Marie get over this if I go and talk to the physician? Because I feel like there's something going on. Remember, Marie hasn't seen the patient. You've been with the patient for the last 2 days. So you have to think about those things. What could have been said or done differently to change the outcome? We've kind of talked about that. Just being more assertive with either or Marie or the physician. How was the nurse acting as the patient advocate? They said no. So she felt like she needed closer monitoring. She really felt in her gut that this patient was septic. And obviously, she went unresponsive and then it became a code. She probably was septic. So it warranted that she did need to go to ICU. So it's just really standing up for your patients when you really believe, because remember, sometimes they can't speak up for themselves or they don't even know what to speak up. If the friend of the patient had been a parent, would the comments have been treated differently? Yes. Right, so a lot of times they think, oh, it's just a college kid. They're just out, they've done it, they've done this and that and the other, and that's why they're in this situation. So, but had a mom been sitting there worried about her child laying in the bed, or we think about it sometimes when we have a health professional in the room with us, and your role changes. You don't mean for it to, but it does. Me as a daughter, when my mom had a heart attack, wanted to know everything that was going on with her. So I made sure I asked questions. But you have to remember that the lay person doesn't know the questions to ask. So it is important to keep everybody in the loop, to not talk. Marie was talking about the little girl like she was not able to hear her. And that's, you don't want to do that. You want to make sure that you treat whoever that is. If the patient wants that person in the room to hear what's going on with them, you want to make sure that that you're treating them with respect and professionalism and different things like that. So you may have wondered why at the beginning she was asking so many questions about all these body systems, and I'm pretty sure she must have been doing her admission assessment. When you do an admission assessment, you'll ask a bunch of questions. They sounded crazy at the time, but I think that's why. And then this is just a summary slide. Like I said, this is already posted on your Blackboard, but Just remember that your assessment is key in determining what's going on with your patient, your gut feeling. One of the most common clinical reasoning errors is making judgments based on incomplete information, but you don't have everything that you need to make a good judgment call. Noticing, interpreting are critical steps in clinical judgment. Poor clinical judgment can result in a sentinel event, sort of like what this lady had in the video. It's important to remember that your patient-specific priorities and needs. So you can't just treat the situation the same every time. Sound clinical judgment provides safe and effective care. Clinical judgment is based on what the nurse brings to the situation combined with objective data. So her vital signs based on what you have experienced in the past. Clinical judgment looks at the whole picture to determine which action is appropriate, and if there is an action appropriate, which one should you do. So I think that's all I have for y'all today. Y'all have any questions? Yes?
You know, I showed the RRT. Would she put in like a progress note or something that she recommended that the patient be moved, and the nurse said no?
Well, you can chart in your notes that what happened. And the RRT, there's a charting process with an RRT. When you put an RRT, it's called, they'll fill out that form as well. So all that goes with the patient. But she's probably not done with that situation, so she's going to keep on and then chart her whole narrative of what happened. Maybe the patient will move, maybe you can get it. Mr. Franklin?
To his question, I would say that if you do put something in your narrative note about you felt like they were supposed to be moved, then you have to take, if you don't, and if they don't get moved, then you have to go to the next step. Because if they go to review your note and that patient dies, it's like, well, you put in your note that you thought they needed to be moved, but you didn't do anything about it. So, just because you do that, you're trying to pass it on. Yeah, but even then, the charge doesn't do anything if you still think it needs to be done.
You kind of at that point taking
If
responsibility.
you go to the physician and the physician doesn't do it, then I mean, he's kind of the higher authority. Does that make sense? That's what I'd say.
No, I was just thinking, number one, I don't usually chart my feelings.
No, I don't.
You don't.
Or my intuitions and the nurse's notes, you know, because it's facts, just facts. And so if I notify someone, I would document that, and like you said, I would document the people that I notified. And it is, I've got it, as Meredith, I have it on me now, it's my responsibility to do something as an advocate for that patient. And, you know, I called an on-call doctor one night, and he told me he was busy having a dinner party. I just turned right around and called the chief of staff. It doesn't take a minute to make a decision, because he needs to know that his on-call person is having a dinner party instead of being up seeing a patient I needed him to see. So, you know, you just have to take the appropriate action, and that's actually the policy that we had in place.
And if you're following policy in the hospital, I mean, what she's doing is she's getting a higher level of care called in that team, that response team. And so she might feel like they're not doing everything, but they are on that team because maybe they have more educational experience or something. You know, so she's done what she's supposed to do. And if you felt like you need to do more, well, then call the physician. What hurt you?
Yeah, the rapid response team can be a good friend for you. So make sure that you use those when you feel like you're just not getting heard or enough advocacy for your patient. So, any other questions? Thank y'all. I think Ms. Jossman has something for y'all.
Real quick announcement. This is preliminary. This is preliminary, and I'll put y'all some references on Blackboard.